Good afternoon, ladies and gentlemen. I'd like to welcome you to another League of Women Voters event. The League of Women Voters is a nonprofit, non-political organization that studies issues, takes stands on them, and educates the public on different issues, which is one of the purpose of our presentation today. We'd like you to join us if you are interested. So, I would like to tell you a little bit about our speaker today. Joe Morris is the CEO Emeritus of Kootenai Health after serving 30 years as CEO of Kootenai Medical Center and Kootenai Health. He has chaired and served 15 years on the Idaho Hospital Association Board and 5 years on the American Hospital Association Board, when he chaired Regional Policy Board 8. He has also twice chaired the Voluntary Hospitals of America, Mountain States. He has chaired Coeur d'Alene Chamber of Commerce, is a board member of Jobs Plus, North Idaho Health Network, and Blue Cross of Idaho. He graduated from the University of Oregon and received his Master's of Hospital Administration from the University of Washington. I'd like us all to welcome Joe Morris.
Well, I think it was summer when I agreed to do this presentation. I've done about 8 health reform talks. It's been a moving target since the legislation had been moving along, and so this would be probably my 8th or 9th one. So it was summer when I agreed to do this. And we postponed it 3 times. The last time I pointed out to Lynn that it was scheduled for the 10th of January. And of course my mighty University of Oregon Ducks were playing in the BCS championship game. So I said, I don't think many people will show up, and I don't think I'll show up either. So we postponed it to today. And I think if I'd won the lottery, I wouldn't be here either, but I didn't win that one either. My goal for this talk, is to present facts. To not get too political on a topic that is quite political and quite controversial for a variety of different people. So my goal is to present the facts as much as I can, to educate and to inform. There'll be questions at the end. I think we were going to have question cards, and so there are some cards that hold your hand up, and Lynn or someone will get you a card and you can write the question on that. I need to read it so that since we're recording this, that the people can hear what that question is. I hit the wrong button. Let me just... There we go. So my agenda is to provide some historical background for coverage in this country, the different things we have done to cover people for health care over quite a few years, actually, and why reform now, what were the big issues that caused us to look at health reform recently. What are the key provisions of the bill? I'm not sure there's a lot of clarity as they read what's in this 2,400-page bill. And so I'll provide sort of what does it really mean for if you're on Medicare, if you're an employer, if you're uninsured. And then I'll provide a time frame. Since this bill passed in March, some of the major provisions actually don't go into effect until 2014. So there's sort of a long time frame for a lot of the provisions. And then I'll try to just talk a little about what's ahead. There was going to be a vote yesterday in the House to repeal health reform. That was postponed a week because of the events in Tucson, and so I'll sort of speculate what's ahead for health reform, and if there are some changes to the health reform law, what could those changes be? And so it's actually called the Patient Protection Affordable Care Act that was signed by President Obama on March 23rd, 2010. It is a big deal. I think this doesn't quite paraphrase the Vice President. I think he was caught off on camera saying something a little different, but it's a big deal for certainly if you're a hospital, if you're a doctor, if you're uninsured. So the history in the United States of trying to cover folks is a long history. Actually, Teddy Roosevelt, when he was running for president, first proposed having some type of health insurance for people. Franklin Roosevelt looked at it when they were putting through Social Security and thought that was too big to bite off, health care and Social Security, so they just did Social Security. Truman called on Congress to provide and pass the national health insurance law. Again, it was proposed health insurance for Social Security recipients in 1952. Medicare was first proposed in 1961. Like most things, they don't pass. It was proposed and failed in 1962. It was proposed and failed in 1963. And then Lyndon Johnson became president, and who's a very strong politician, had been in Congress a long time. And under Johnson, Medicare and Medicaid were passed. What's sort of interesting to folks, Medicare is actually the name of the Canadian health system. And so he's copied the Canadian name and used it in the United States for those over 65. And again, Medicare 65 and over, Medicaid for low income and pregnant women. Medicare was expanded to the disabled, and so is the elderly first. And then if you're on disability now, you're covered by Medicare. Nixon proposed a national health insurance plan in 1973. Carter proposed national health insurance in 1977. I like this because people think this is a Democrat, Republican. It's really both sides of the aisle have proposed health reform. In my State of the Union message, I pledge to present a program to assure that no American family will be prevented from obtaining basic medical care by the inability to pay. I'm announcing that program today. What I'm proposing will require employers to provide basic health insurance for their employees. In the past, we've taken similar action to assure workers a minimum wage, to provide disability and retirement benefits. We should go one step further and guarantee that all workers will receive adequate health insurance protection. And so that was proposed in 1971 in his State of the Union message. And so the Nixon plan had an employer mandate, had a basic benefit were outlined, a subsidy for low-income individuals, expanding Medicaid and Medicare. I mean, a lot of things actually that are occurring with the current bill. And HMOs, it was sort of a new thing back then, proposed under Nixon. Again, in 1988, Medicare Catastrophic Coverage Act was really the largest expansion of Medicare. This was under the first President Bush. So some outpatient drug benefit, outpatient care, a cap on out-of-pocket expenses, extended hospital and nursing home coverage. So it was a major expansion of Medicare in 1988. As you know, in 1993, Clinton, had his famous proposal, and it was really much different than what occurred this last time around. I mean, it was really done outside of Congress and then brought to Congress and said, here's the bill, pass it. And of course, Congress didn't pass it. And so the Clinton attempt to cover a lot more people failed in 1993. But Medicaid was expanded beyond welfare in 1996. The Children's Health Insurance Program that covers kids up through 18 went into effect in 1997. And then under the next president, those were all under Clinton, under the last President Bush, the Medicare prescription drug benefit, or Part D, passed. And then Part D will be affected by this current reform in a lot of different ways. And then in 2009, as President Obama first came into office, the Children's Health Insurance Program was expanded. And then last March 2010, the Patient Protection and Affordable Care Act. And so it's a long history of a lot of years of covering people through a lot of different programs. Joel Chafee, these are Republicans in the 1980s, proposed individual mandates, cap on copays and deductibles, eliminating pre-existing conditions, the way health insurance is sold. John McCain, the health insurance exchange that you'll hear about, is a John McCain idea and was proposed by him. And so when countries look at expanding coverage to more of their citizens, it really involves political, economic, medical decisions. I think the question most countries ask is, should we guarantee medical treatment to everyone who needs it? And most countries do it in very different ways. A U.S. poll showed that 79% of people in this country want fundamental changes or complete overhaul. And so it's easy to agree on that. It's just as hard to agree on the details, as we found out this last time around. So I thought I'd give you, I'm next going to cover different models for health insurance and how different countries do it. So I thought I'd give you, you folks, since you look very smart out there, a little quiz just to see if you can name the country that I'm describing, because I think there's a lot of misconception as to how other countries provide health care coverage to their citizens. So this country is number one in all statistics and satisfaction as far as the World Health Organization is concerned. It's number one in citizen satisfaction, has private doctors, private hospitals, private not-for-profit and public hospitals. You can keep your health plan for life. nonprofit plans, no denial of claims, 5% administrative cost, co-pays on all services, no limit on choice. They spend about $3,165 per capita. We spend about $7,000 per capita. It's illegal to opt out of the health insurance plan. 90% of the people buy a supplemental health insurance policy. The government negotiates prices and sets the prices for all hospitals and doctors. Doctors are paid in 3 days. The law says they have to be paid in 7 days. And you carry around a card wherever you go, and that card is sort of your key to entry into the system. Any idea what country that would be? France. France, yeah. A very smart group. The next one, it gets a little harder. The next one mandates health insurance for employers and employees, and so it's shared. The cost is shared by the employer and the employee. There are 200 private plans. They spend 11% of the gross domestic product on health care. We spend 17%. Government controls prices. They have a universal smart card as well. They have a 125-year history of mandating coverage through the employer. They have nonprofit insurance plans. If you lose your job, your unemployment benefits has health insurance attached to it. And you can change your health plan anytime you want to change the plan. Or you can keep the same plan for your entire life. And so which one is that? And so the key clue there would be 125-year history. Germany, under Bismarck, actually developed a plan. And then the next one, this country has private doctors and hospitals. The average citizen visits a doctor 15 times a year. They have twice as many CAT scans as the Americans have, and that's saying a lot. The average hospital stay is 36 days, ours is 6. The government has a nationwide book of prices, and so that's what determines how people are paid. Minimum fees, no waiting times, most competitive entrepreneurial doctors in the world. They spend 8% of their gross domestic product on health care, half of what we do. 30% copay, $650 per month cap. They have 3,500 health plans. Premiums are split between the employer, 55%, and the employee. Retirees and small business individuals and local governments split the cost. They have a personal, not really a personal mandate, it's just a personal expectation that as far as a sense of personal responsibility, you're expected to buy health insurance. But if you don't buy health insurance and you enter the system, you have to pay back all the premiums you have missed before you get any coverage. And so that's their, so it's not an individual mandate, it's just a strong incentive to cover. So what country would that be? Japan. That's Japan. And then the last one is my easy one. This country has no co-pays, no health insurance premiums, no fees. Government owns a hospital, pays the doctors. Specialists work in hospitals as government employees. General practitioners remain private. Patients register and pay capitation. Administrative costs are 1/5 of the United States. And so we really essentially never get a bill under this system. And you don't pay any premiums because it's funded out of general revenue, general taxes. And that would be Great Britain. And so those are there's actually so you did very well. You're actually the best group for my quiz so far. And so the Bismarck model, which was developed in 1883 in Germany, the providers and payers are private. The employer and employee finance through, they share in the cost of health insurance. They have tight regulations of medical services and fees. And so this is Germany, Japan, France, Belgium, Switzerland, a lot of the Latin American countries. And so a lot of countries follow this. You know, there's no government health plan, you'll notice. The Beveridge model is the British model. And healthcare is financed and provided by the government. It's financed through tax payments, no medical bills. Government is the sole payer for healthcare. And that's Great Britain, Italy, Spain, Scandinavia, Cuba. The national health insurance model, the providers are private, so the doctors and hospitals are private. The payer is the government, and so it's a single payer system. Every person pays into the system, and so that's the Canadian system. You know, they have private doctors, private hospitals, and so that's Canada. Taiwan's interesting because Taiwan has been late in covering their citizens, and so there was a famous health economist, you know, who worked in the United States, who actually I had read when I was in graduate school. But they asked him to come back home and help them study the different plans around. Their bias was that we should do what the United States does because they really like the United States, but they ended up choosing the Canadian system, essentially. And then there's the out-of-pocket model, which a lot of countries have, certainly in the third world. Care is paid for by the patient out of pocket. So there's private doctors, private hospital, and so your access to health care depends on your wealth and your ability to pay. And this is obviously Cambodia, India, Egypt, those type of countries. Now for the United States, the question is, what kind of system do we have? Well, we're really the only country that has a combination of systems. For people who are insured through their employer, we're Germany, France, those countries. For Native Americans, military personnel, veterans, we're Britain. Government hospitals, government doctors providing the care. If you're 65 and over, disabled, or end-stage renal disease, then we're Canada. You have the Medicare is a single payer. If you're one of the 51 million uninsured in this country, then we're Cambodia, India, Egypt. And so we have, no country has so many different systems that we have. No country relies so heavily on for-profit insurance plans. All of the other countries generally have one model and most of them do not involve government hospitals, government health plans, government doctors who work for the government. The World Health Organization, there's 191 countries ranked by fairness and equity of systems. The U.S. ranks 54th. If you look at deaths per 1,000 births for people under 75, we're 10th behind Poland for various chronic diseases. When I say that we are path dependent, there's a great article by Atu Gawande in the New Yorker that talks about how do countries end up with what the system that they have. And it's really because of where they started and the parts they have to put together. I mean, England became a government-run system because during World War II, they were being bombed every day by the Germans. And so the government took over the hospitals to take care of all the casualties that were developed. And after the war was over, the government was going to turn the hospitals back over to the private owners and turn the system back over to private individuals. And the citizens of Britain said, we sort of like the way this thing is working, and so we want to keep our system. In the United States, by accident, we came upon private health insurance. I mentioned I'm on the Blue Cross board. During World War II, there were wage and price controls. And so you couldn't raise wages. And so someone went to the Wage Stabilization Board in the United States, an employer, and said, what about health insurance? Is that a wage? And they said no. And so some employers started offering health insurance to attract employees, and employees were very scarce since a lot of people were overseas fighting in World War II. And so health insurance started out in the United States as employer-sponsored. And so we're going to have mainly an employer-sponsored system to a large extent. Other countries ended up with and each country has different values and different cultures. And so those are sort of the different models for what countries have done to cover their citizens. And the reason health reform keeps coming up is that there are two trends that everyone, I think, agrees are not sustainable. And those trends were the rising increase in the cost of health care and the rising number of people who don't have any health insurance coverage. Just to give you the evidence, on the cost side, the number one cause of bankruptcy in the United States are health care bills. Projected costs are expected to double by 2020. The states, including the state of Idaho, are finding the Medicaid increase is unsustainable. Medicaid enrollment in the last year in Idaho has gone up 9% as people have lost their jobs. The Medicare Trust Fund was scheduled to go bankrupt in 2017, and that's what you're payroll deducting into the Medicare Part A Trust Fund. And we're spending more money out of it than the money that's going in. And so that was scheduled to go bankrupt by 2017. The health reform law extends the life of the trust fund to 2027. And then employers are bailing out in this country. We've gone from 72% of people getting their coverage through their employer to 56% in 2009. And I think we're headed below 50%. And a lot of it's the types of jobs we have, the types of jobs that have gone overseas. Certainly the General Motors that were much larger had great health insurance and probably covered the family as well. So health reform, why health reform now? The growth in the public budget for health care is unsustainable. Private health care costs are increasingly making the U.S. Non-competitive on a global basis. Health outcomes aren't good compared to other countries. And the improvements in cost and quality are impossible when large numbers have no coverage and no way to pay for their health care bills. This shows the percentage of gross domestic product. The trend line, as you see, right now we're about 17% of our gross domestic product is spent on health care, more than any other country in the world, twice what Japan spends. I think I mentioned Germany was 11%. If you look at the G5, those are the major industrialized countries. They spend about $1.98 per hour in health care, where we spend $2.71 for our employees. And so in a competitive global environment, U.S. manufacturers and businesses are at a disadvantage. And then this is sort of a hard graph to read, but I'll try to use this thing. This is you can see this is increase in wages, this is increase in the CPI, the Consumer Price Index, and this is the increase in healthcare expenses. And so obviously going up much more. And then this is the cost per family. And you can see the cost per family is a percentage of your income. If you're paying for your entire family out of your pocket, in the United States it's 24% of family income. And then I mentioned the deaths per thousand population, and this is for under 75 for certain chronic conditions. You can see the United States we haven't made much improvement. The first graph is 1997 to 1998, the next one 2002 to 2003. And so some countries have made significant improvements. We haven't made many improvements, and you can see our deaths per thousand for those chronic conditions is higher than a lot of other countries. And the other issue beyond cost is a rising number of uninsured. When I started giving this health reform talk, the figure I was using was 47 million uninsured in this country. But the number's gone up while we've debated health care reform. So now, I think it's 50.9 or 50.7, so I round off to 51 million people in this country have no health insurance, projected to be 66 million by the Commonwealth Fund by 2019. And the ability to cost shift is getting limited. And what cost shifting is this wonderful social program of hospitals where we charge a lot more for those who have health insurance to be able to have enough money to cover those who can't pay their bills. I think at Kootenai it's around $30 million that we have to raise to cover the uninsured who walk through our door. And then you can debate this last one, but there are lots of studies that would say that people who do not have health insurance enter the healthcare system later than those with insurance. They have less preventative care, and they die more often of the same disease as people who have insurance. And so the range is the lowest I've seen is 25,000 people die each year, and the highest is 45,000 due to a lack of coverage. In Idaho, it's 217 million. This is like a year-old figure, so given our economy, it may have increased beyond that. Almost 15% of residents. I was on a committee, a task force the government put together a couple of years ago, and we look at it per county, and in North Idaho, it was generally 20% or above, or 1 in 5 people in the 5 northern counties did not have health insurance coverage. And I mentioned the cost shifting. This is sort of a clever little slide that shows that, to cover the cost of the uninsured, you have to add on, that yellow portion on the right. You have to charge more for those who have insurance. And you can't do that to Medicare. You can't do that to Medicaid because they set prices. And so it's really those with commercial insurance, you need to charge more so that you have enough money to cover those who can't pay their bill as they walk in. Interestingly enough, the United States is the only place where you can walk into a hospital, only country in the world, I think, where you can walk into a hospital with no health insurance and get care, whatever care is necessary. If you have cancer, you can have your cancer taken care of. Other countries, you either have to have insurance, or in the countries like Egypt and India, you have to be able to pay out of pocket before they'll provide that coverage. Again, the 8% surcharge on families is sort of the hidden tax that we charge folks to cover the uninsured. And so the problem is, and this is sort of the cycle that we get into, hospitals write off the care of the uninsured but raise prices to cover, so we pass it on. Insurance companies raise their premium because we've raised our prices, and they pass it on. Employers get hit with a 17% increase in premium, so they either increase the deductibles that their employees are paying or make their employees pay some of the premium and raise their prices to customers. Sometimes employers then drop their health insurance coverage, which adds to the uninsured, which means that the cycle starts all over again. And so that's sort of the cycle we're in as the rising number of uninsured has increased in this country. And then often you'll see, well, the free market should fix everything. The free market will keep costs down. But there's no free market in healthcare because the consumer, which is the patient, consumes but generally doesn't pay. It's the employer who's paying the bill or the government. The payer pays but neither buys nor consumes the service. The buyer, which is the employers and the government, buys but neither receives a service or a product. And the provider of the hospitals provides the service or product to the consumer, but that person is neither the buyer nor the payer. I have you confused by now, I can see that. And so there's not this free market. I mean, the free market would be if the employer were to give their employee, here's some money. You go out and buy your own health insurance and take care of your own health care. But that's not the way it works in our country. And so getting to reform, you're wondering when I was going to get to reform here. This is sort of my background. These were the folks, the different organizations that supported health reform as it wound its way through Congress. And you can see it's the Catholic Hospital Association, the AARP, the American Medical Association, the device manufacturers like Medtronics, the drug manufacturers like SmithKline and Novartis, Pfizer. The health insurers were even on board until the very end. And then in the last couple weeks, they ran for the exits for an interesting reason. They thought the individual mandate was too weak. I mean, the biggest fear of health insurance companies is they'll be required to sell you a policy, and you can buy that policy whenever you want to buy that policy. And so when you need a total hip, you can come and buy the insurance policy. Then when you've had the surgery, then you can drop the policy until you have another medical need. And so they think there should be a strong individual mandate in order to make sure that everyone signs up so you have a large, healthy pool. And they didn't think the individual mandate or the employer mandate were strong enough, and so they posed it at the end. The first thing that I like this slide. It's the first thing that went into effect, and this was last July. It passed in March, was a tax on indoor tanning salons. I'm speculating that it may affect a couple people in Washington, D.C., who look unusually tan in what is not a really sunny city. So North Idaho, what does it mean? What does this bill that passed mean to everyone here? Well, just to put it real succinctly, there's certain key provision. It provides coverage to 32 million uninsured people by 2019. It reforms insurance practices to protect consumers. It builds on the existing employer and government-based insurance programs, sort of that path-dependent thing. Delivery reform, it tests a lot of different ways to tie payment to hospitals and physicians to quality improvement. And so if you're a doctor or a hospital, there are lots of different things that are proposed for how you're paid. So the 10 big things to know. It requires all Americans to have health insurance coverage. That's the individual mandate. No coverage exclusions for pre-existing conditions in 2014. No lifetime benefit limit and no annual limit on coverage. Individuals cannot be denied coverage based on their health status. Allows dependent adult children to stay on their parents' policy until age 26. Mandates coverage of preventative care. No cancellation of coverage when someone becomes sick. That's called rescission. Limits insurers' ability to set premiums based on health status and other factors. I mean, they only have like 3 bands, I think, that they can have in setting a premium. It creates a health insurance exchange to help people find health insurance. And I'll talk a little more about these exchanges. And it provides subsidies to help people buy insurance. And the subsidies go all the way up to 300% to 400% of poverty, federal poverty level. And so these are sort of the different people affected, and I'll just sort of quickly go through each one. If you're insured in an employer-sponsored plan, it's probably, you're not going to see much in the way of change. Or if you're buying your own coverage now, you probably continue to buy your own coverage, but you can go on the exchange to do it. If you're an employer, most individuals will see their coverage through their employer, should not see substantial changes. The bill includes incentives for some employers to offer insurance. If you're buying your own coverage, you're an individual purchaser of care, you're eligible to get your coverage through the insurance exchange. You qualify for tax credits to help purchase the coverage. If you're on Medicare, I think there's a lot of confusion on this one. If you're a Medicare beneficiary, You really shouldn't see much in the way of changes. There are some enhanced benefits, most of which went into effect this last January 1, or 13 days ago. Free preventative screenings such as colonoscopies and mammograms, free annual physical or wellness visit, discounts on name brand drugs, a 50% discount on name brand drugs if you hit the donut hole. The donut hole is Part D. You have drug coverage for the first couple thousand, then you have no coverage for a while, then coverage kicks in again. So that spot in the middle where you have no coverage for the cost of your drugs is called the donut hole, which eventually disappears, I think, by 2020. But this year, as of January 1, you get a 50% discount on name brand drugs when you're in that donut hole. Some individuals, Medicare Advantage is where Blue Cross will take the money that the government normally spends on a Medicare enrollee in a county and gives them an additional 20%. And Blue Cross then, they're at risk for the health care that you consume. Medicare Advantage has had an advantage itself of getting 20% more than the average cost of a Medicare enrollee in a county. And so that 20% advantage is going to be whittled away over time. But I still think Medicare Advantage plans will stay around. If you're uninsured, you don't have any insurance, then beginning in 2014, all U.S. citizens and legal residents must have coverage or pay a penalty. And this is probably the most controversial part of the entire bill. You know, this is the individual mandate. This is the one where there are numerous court cases winding their way through circuit courts and appeals courts. You know, the question is, constitutionally, can you require an individual to consume a product or buy insurance, essentially? And so that's sort of the basis of that. And I'll talk a little more about that. Uninsured individuals have access through the insurance exchanges, and there will be subsidies available to low-income individuals to buy private insurance. Again, if you're uninsured, Medicaid gets expanded, and this is another controversial part, is expanded to low-income individuals up to 133% of poverty. Right now it's 100. And so the Medicaid, about half of the 32 million who get covered under this health reform program are covered through Medicaid. And that has the governor's concern because the state has some money on the hook. Although during I think during most of the 2014 on, the new enrollees, there's a 100% match from the federal government. Starting in 2010, there's a high-risk insurance pool. So how do you take care of the folks who have pre-existing conditions? There's a high-risk pool that's available to individuals with pre-existing conditions until 2014, when you can't take into account pre-existing conditions. And then it expires in 2014 because of the insurance changes. So I talked about the insurance exchange. I think what Congress was doing is trying to put something in place that they have. You know, if you're a member of Congress, if you're a federal employee, every year you go online and look at all of the various health plans that are competing to have you buy their product. And there's no pre-existing conditions because the government essentially has made the market. And so Congress, that's how they buy their health insurance, and all their staffers. They just go online, pick the health plan that they want. If you have a real rich plan, you're going to pay more out of pocket. If it's a lean plan, you may get some money back. So you can pick a plan that suits you, and that's sort of a national. But the exchanges the states have the option, they can start their own exchange, or if the state declines to start an exchange, then the federal government will do the exchange in that state. I think most states, including Idaho, will want to have their own exchange because there can be a lot of difference in how states approach it. If you're a large employer or a small business, large employers with 50 or more will be fined if their employees purchase health care coverage through the insurance exchange and receive a subsidy. Although I've talked to an employer in Idaho, a large employer, and he thinks that the penalty for the employer and the penalty and the subsidies going up to 300 or 400% of poverty would allow him to essentially pay his employees more money, not pay health insurance premiums. The employees would be better off, and the employer would be better off because of the high level of subsidy. So that's why I say some employers view that as a sort of a win-win. Small employers, small businesses are eligible for subsidies to offer insurance and have access to the exchange. And so if you're an employer with 10 or few employees and the average salary is $25,000 or less, you can get a 50% tax credit. And that was, if you have 25 or more, then you can get a partial tax credit. So that's an incentive. There's no penalties for folks, for employers under 50. It's only for employers over 50 employees. So the time frame, and when health reform passed, I got a call from a reporter saying, well, what do you expect? What's the big change going to occur? I said, I expect we'll see an increasing number of uninsured until 2014, because that's when coverage first kicks in. But in 2010, again, no limit on lifetime benefits. This has already gone into effect, so it's already law. Appeals process and patient protection for all new plans, dependent children. Children with pre-existing conditions cannot be denied coverage. That went into effect in September. Insurance reforms, new plans cannot cancel coverage for individuals if they get sick. No discrimination based on salary. Insurers will be required, and this went into effect January 1, recently. Insurers will be required to spend at least 80% of all premiums on medical services. And so for every dollar they take in a premium, they have to spend 80% for medical services. If it's a group, it's 85%. It may not affect the amount. Blue Cross doesn't think it's going to affect them, but some plans, they're as low as 70 to 65% of the premium is spent on medical services. Coverage, high-risk pools I mentioned, so there's a national strategy to improve the delivery of healthcare services, so lots of pilots and studies put in place. Again, in Medicare in 2010, it was a $250 rebate if you hit the donut hole, and small businesses had a tax credit in 2010. 2011, this is a January 1, again, you get a 50% discount on name brand drugs and offers a comprehensive health risk assessment, a new benefit. 2013, families with income above $250,000 will be required to pay an additional 3.8% tax on investment income. So that has some accountants concerned as to how you track all that stuff. And you contribute more to the Medicare program and payroll taxes. And so it's an increase in your payroll tax through that income level. In 2014, and this is sort of the big date, most Americans will be required to have health insurance coverage or face a federal penalty. The fine would start at $95 per person or $285 per family or 1% of taxable income. And then it gradually goes up. Again, insurance reforms going the same time the individual mandate goes into place. The insurance reform where you cannot refuse to sell a policy because a pre-existing condition goes in, because the two are directly linked, at least in the eyes of the insurance companies. Then this is when the penalty for large businesses goes into effect if their employees go on and get a subsidy from the government. 2016, the individual penalty and the penalty for businesses goes up. And so by 2019, what have we done? How have we covered folk? And you can see that, we've gone from 51 million uninsured to 31 million, to by 1919 down to 23 million. There's still, the plan only covers legal residents of the United States. And so unless you're a legal resident of the United States, you're not covered. And therefore, you're going to have a large number of those folks who are not covered. And so we still have 23 million uninsured in the country. And then, another big question is, how's all this paid for? It's a combination of new revenue and reductions in expenditures. And I'll try to point some of those out. The Medicare, this is sort of the sources, and these are the uses of funds. And so Medicare taxes, those are for the folks over $250,000 whose Medicare tax goes up. Market basket updates, hospitals agreed that we would give up, and this is on hospitals, we would give up $157 million in future increases in reimbursement if more people are covered. And we wanted to backload it so that if 32 million more people have health insurance, and we don't need to be paid as much as we do now because we don't have the charity care and bad debt burden that we have. Medicare Advantage plans are cut back to more what the average is in the county for Medicare enrollee. Industry fees, there are fees on device manufacturers, drug manufacturers, home health agencies receive some reductions. There are really these are all cuts to providers, to manufacturers, to drug companies. That's where you hear the $500 billion in cuts. From a Medicare enrollee, and I'll be surprisingly on Medicare in 2 years. I think that for a Medicare enrollee, you have generally better benefits, same plan that you have now. The uses, again, are Medicaid and CHIP. Half the money is expanding the Medicaid program. Exchange subsidies, employer tax credits, and so you have a total. And then there's a tax that goes into effect in 1919 on Cadillac plans, real rich. If you're spending like more than $12,000 in an individual, more than $27,000 for a family, that's a Cadillac plan, and they get taxed. The Congressional Budget Office actually, and sort of reaffirmed that recently, when you look at the end of the day, if you repeal health reform, that increases the federal deficit by $143 billion. And so the federal deficit between now and 2019, through all of these changes that they've made, actually gets reduced by 143. There's some delivery system reforms as well. I mean, there's not a lot here that affects the cost curve, and the whole idea is to somehow bend the cost curve so it doesn't keep going up like I showed you. And so there's a lot of experimentation going on. One, there's going to be a lot of transparency. You'll be able to go online and look at prices, quality scores, satisfaction scores for all healthcare providers. They're experimenting with bundled payments where doctors and hospitals and post-hospital caregivers get one payment, and then they have to figure out how they're going to divide it among themselves and how they can be more efficient. There's something called accountable care organizations, and sort of an organization made up of doctors and hospitals like the North Idaho Health Network that goes at risk for a whole population of patients. If you sign up for a family physician who's a member of an accountable care organization, essentially the money goes to the accountable care organization, and if you consume a lot more health care than is expected, then it's that organization that's at risk. Medical homes, I mean, there's a lot of discussion that the way that we shop for our healthcare services is going to specialist to specialist, from specialist to specialist, demanding MRIs. That a better way is to have a medical home, a primary care physician who's sort of your doctor, who helps manage your care, who decide when you need to see a specialist. And so there's a whole lot of experimentation in Idaho and elsewhere. And doctors like this idea, and family physicians especially like the idea of a medical home. But you'll hear a lot of discussion of that. Value-based purchasing actually kicks in, where hospitals are going to be paid based on 17 quality indicators and patient satisfaction scores. And you can have a 2% bonus or a 2% penalty in your Medicare reimbursement depending on your scores. And so that's starting next year. But there's really a rush away from fee-for-service. If you pay someone for every CT scan, for every MRI, for every office visit, if you pay for volume, you get volume, which is why we spend double what anyone else spends in the world on a per capita basis. And this is a little tricky slide, but it shows sort of the move away from fee-for-service, where you pay for coordination of care, you pay for performance, you bundle payments, you sort of share savings through these accountable care organizations. Capitation would be where an organization like the North Idaho Health Network just takes the premium from, say, Medicare and is responsible for all your health care. The idea is that there's really an incentive to keep you healthy, to provide preventative care, to keep you out of the hospital. And so a lot of experimentation on the provider side, and a lot of changes coming on the provider side. Well, next I thought I'd talk about what are the prospects going forward on health reform. We had these November elections, and so the November election caused some changes. The main change would be in the House, where you can see the Senate pre-midterms went. The Democrats still have a majority, went from 59 to 53, but in the House, the Democrats had 257. They had majority. Now the Republicans have 242 to 193 for the Democrats. So the Republicans took over the House. And so all the budget committees that were chaired by Democrats are now chaired by Republicans. And so there are really three options that they're looking at. One is to repeal. And again, a repeal vote was scheduled for yesterday and was probably going to pass. They postponed it. It'll come up next week, and I think it'll pass the House. At least one of the procedural votes they had, they had enough votes to pass it. You can repeal and replace. The repeal bill is like 3 or 4 sentences, and so it's a very small bill that will be voted on. There's a repeal and replace, by repeal it and then replace it with something different. And then change some of the discrete elements, affect the funding where there is discretionary funding, and then invite you can hold hearings. You know, if you're the chairman, you can hold hearings on lots of different topics, and so you can call Don Berwick, who's the head of CMS, to explain why they're doing certain things. And so you can see the feasibility. The repeal will probably pass the House, but the Senate is still has a Democratic majority, and the Senate, as you know, is sort of a cumbersome organization. You only need 60 votes to get anything done. And even if it were to pass the Senate, the president has said he'd veto the bill. And so repeal is not going to take place. But there may be some changes, I think, to the existing bill. And I'll show you what I think some of those changes will be. This is, again, the sort of the repeal and replace. It was a pledge to America the Republicans signed on to. And their plan was tort reform, which hospitals and doctors like. Incentivize people to use health savings account, use high-risk insurance pools, prohibit insurers from excluding you because of pre-existing conditions, but there's no individual mandate. Allow for purchase of insurance across state lines. And so I think you'll see some attempt to put in some version of these over the next year. And here's sort of where again, but a lot of things have already gone into place. And so if you do repeal health reform, these are the things that go away. And there are about 11 different things that disappear that have already gone into effect and are already law in this country. So what can change? And I think these are where you'll see some attempts to make changes from a variety of different sources. The medical loss ratio, insurance companies don't like that generally. And so there may be some attempt to say, well, it's not a mandate that they're required to spend 80% of every premium dollar on medical services, but they need to publicize what their ratio is. And so when you're buying your health insurance, you can say, well, I want a plan that spends a lot more of the premium dollar on health care than one that doesn't. That might be an attempt. There's this independent payment advisory committee that's really not advisory. It can recommend changes to how healthcare providers are paid, and Congress has to vote those changes down. They go into effect unless Congress votes them down, and Congress has to vote them down. They can't change them, and so Congress has given up some authority, and I think there may be some attempt to weaken the Independent Payment Advisory Committee. There's some tax reporting that occurs for individuals and businesses I think we'll try to eliminate. Individual mandate, that's where the biggest battle I think will be. And I think there may be, and if you could figure out how can you provide a very strong incentive for people to buy health insurance without a mandate and without a penalty, but a very strong incentive, and the Congressional Budget Office would score it as covering 32 million people, then you eliminate a Supreme Court showdown over this issue. And so, but how you do that is a trick. Australia does it to some degree. They have a real basic plan, and so then everyone generally buys an add-on plan. But you lock in a price for that add-on plan. The younger you are, the lower the price, sort of like long-term care insurance. And so there's such an incentive that young people buy it, and therefore they have the pool spread among young and old, which you need. I saw Blue Cross at a Blue Cross board meeting recently. They're sort of looking at how are premiums going to change under this. And if you're one of the young invincibles, which means you're 25 years old and think you're never going to get sick, your health plan goes up 191%. If you're 55 years of age, your health plan is almost, your health insurance premium is almost cut in half. And so that's how some of the premiums are affected, because you can't have the bans you have now, you can't have the pre-existing conditions that you have now. I think they'll scale back some of the funding for the Internal Revenue Service to track this stuff. I think the state insurance exchange, this orbits of healthcare, are going to be very different depending on the state. California is going to be very regulatory. You have to meet certain conditions to have your product offered on the plan. Whereas in Utah, Florida, I think they're going to want anyone who wants to sell a plan through the exchange. There's even a provision where different states can get together and have a sort of a regional agreement and then one of the Republican platforms was selling insurance across state lines. You could create that with a regional exchange or an agreement between exchanges, say in the Northwest. The governors are pushing back on this one. I mean, Medicaid goes from 100 to 133% of poverty. Half the new 32 million people get covered are on the Medicaid program. And so they may try to push that back, that poverty level. And then the individual subsidy, and these would be on sort of the deficit reduction side. I mean, the individual subsidy it goes from 3 to 400% of poverty. So a family of 4, that could be $90,000 of income. And I mean, there's some sense that, well, maybe that those are a little rich as far as the individual subsidies are concerned. And the device manufacturers, who are paying the tax, may want that tax eliminated. There's some sense that I think the Chamber of Commerce has stepped in saying, if you tax the manufacturer, you tax the insurance companies, they're just going to pass it on to whoever buys a product, whoever buys a policy. But I think this is where you'll see, and so generally it doesn't look like there will be a vote in the House, but probably not a vote in the Senate, and if something were to pass the Senate, the President would veto it. But I think this is where you'll see the action and probably some changes occurring with existing laws. And it generally occurs, when you pass something really big, it's 2,400 pages that very few folks have read, changes then occur at a later time. I think the different scenarios go out beyond 2000. If you look at sort of different scenarios, repeal of the health reform bill would cost $145 billion, increase the deficit by that much. The HJR2, which is the repeal of health care, would increase the deficit by $230 billion. I think the real thing is the question is going to be what's going to happen in the 2012 elections. And so I think the different scenarios are if the Republicans take the Senate and President Obama is reelected, then he still has the veto ability and you still need 60 votes in the Senate to repeal something. If the Democrats hold on to the Senate, then you probably have what you have now. If you have a Republican president and Republican House and Senate, then that Republican president would go into office at late January of 2013. And the big coverage reform stuff goes into place 2014 or 11 months later. And so the question will be, are you already so far down the road with this train that it's going to be hard to completely repeal, but you'll be able to make certainly changes on them. And so I think those are the possible scenarios looking forward. And that's the slide you're all looking for. And so that's hopefully give you some sense for the long history we've had with covering folks and the various attempts we've had, what other countries have done, how we're different from other countries, what's in the health reform bill, where the money comes from, what it costs, how different parts are affected, and some possible scenarios going forward, because this is a democracy and laws can change, and as people get into office, they can change laws. And I think there will be some changes as there are in all big passages of bills that we've had in this country. So with that, I think I'll read the questions from the cards, if there are questions on the cards. My trusty assistant here who talked me into doing this in the first place. Does the risk of epidemic swine flu, for example, influence the decision for universal health care? No, I don't think. I mean, we dealt with a little pandemic last year. It's amazing how soon you forget it. But I remember, we were meeting every morning at the hospital, when H1N1 was coming through town and affecting younger folks, actually, and not generally elderly. I don't think that's the case. I think in a way, I think what influences health insurance reform is that we don't stack up very well against other countries when you look at health outcomes. And so it's an attempt to try to provide preventative care to more people so our system is less costly. How do we reduce costs without a single payer system? Again, Japan has 3,500 insurance companies. And so what occurs in most countries is they have lots of different insurance countries. They don't have a single payer, but the government sets the price. And the government actually in the United States, Medicare, everyone copies Medicare. I mean, Medicare comes up with a way to reimburse hospitals. Every insurance company copies it the next year. they don't always pay the same rate, they pay a little bit better rate. Medicare changes the way they pay doctors, every insurance company changes the way. And so Medicare determines how we're paid, but not the level at which we paid. But I think the hope is that all these experiments with accountable care organizations, you shift the risk to the providers, and that will require them to be more efficient and to keep people well. What provisions are there for dentistry coverage? I know of no provision for dentistry coverage. Will there be Medicaid reform regarding waste or mismanagement? Well, there is a lot of, there's so much money in healthcare, there's a lot of fraud. And so you'll see a lot of fines have been paid. I think recently in Florida, they were billing for patients that didn't exist. They were billing for procedures they didn't perform. And so I think the figure I've heard is like $124 billion of fraud takes place in this country. And so trying to, the fee-for-service system encourages it. And so if you change the fee-for-service system to a more global payment, then I think a lot of that fraud goes away. What is interesting, I think, is that Medicaid is a government program. Medicare is a government program. Sometimes people say, don't let the government fool around with my Medicare. Well, it is the government. It's a single payer. In other countries, like in Germany, you turn 65, you stay on your health insurance plan. You aren't forced to switch to a government health insurance plan, which is Medicare. Why did hospital associations support healthcare reform? I think the American Hospital Association, which has a board, supported health reform because they see sort of a disastrous scenario. We have an increasing number of uninsured, increasing number of people with bad debt. Our ability to cost shift, I think that game is ending. The last budget we did, it was ending at the hospital. We said, we can't, I think the last month I was looking at a financial statement, 29% of the patients in October at Kootenai had commercial insurance. It's the lowest it's ever been. That means the rest are Medicare, Medicaid, uninsured, bad debt. And so when you get down to only 29% of the people you're trying to cost shift to, it's difficult to charge enough to do that. And so I think most of the folks who are in healthcare think that something has to be done. Not everyone agrees with what was done, but they think something had to be done because, again, the rising number of uninsured and the rising cost is not sustainable. We did the American Hospital Association. How would KMC be impacted? They did send out some modeling, and you get cut back. It's $157 billion. We get cut from some payments we get because we take care of a lot of uninsured. Those get cut back and eliminated. Our updates get cut back, but we have more people who are being covered. And so it's about break even, maybe a little to the positive side for the hospital. And there's not an expectation that you're going to provide a lot more hospital care. I think in Massachusetts, which has already done this, sort of, the lineup was at the primary care physician office. People could not get in to see a primary care physician because the first thing that people who had insurance wanted to do is find that medical home, find that family physician. And that's a problem in this state. We have very few primary care physicians. At Kootenai, we're planning to start a family practice residency, where eventually we would be graduating 6 family practice residents a year to try to address the shortage of primary care physicians. You all write very neat, I might say. At this point in time, could we pass Medicare if it were not in existence? Well, that's a good question. Medicare was controversial when it passed. I think the American Medical Association was against it, but it is a fairly efficient plan. Their overhead costs are less than almost all other insurance companies, and so I didn't think I lost 2 bets. I won a bet and I lost a bet on this over the last 2 years. I bet that there would not be a government option. Remember there was this talk of under the exchange there'd be a government option, and I said that'll never happen, and I won that bet. But then I lost the bet because I didn't think this would ever pass, and it passed. So I broke even on dinners. I think there's another one. I think I've covered most of them. Prescription drug advertising. I think it says Estonia prohibits TV marketing. Actually, it was against the law to advertise drugs in the United States until 1997. And so we didn't, and most countries don't allow you to advertise drugs on TV because then you all want the drugs. So you go to your doctor, say, I want that drug, and it increases consumption. So most countries, it's not the one mentioned, most countries do not allow the advertising of drugs, but a lot of them, and then a lot of them set prices for drugs as well. And so drug companies spend a lot of money to try to convince you that you need the drug, and they spend a lot of money marketing to doctors. I think it's like $12,000 to $14,000 per doctor they spend detailing the doctor to try to explain how good the drug is and why they need to prescribe that particular drug. And so, you know, I mean, because you needed a lot of, to get this passed, you needed a lot of people at the table. The drug companies have a very strong lobby, and this passed because the drug lobby agreed that this should pass. I mean, they take some hit, but they also have a provision where you can't bid out drug prices. I mean, the VA can do it, but the Medicare program cannot bid out drug prices and say, give us the lowest bid for this particular drug, and then we're going to pick that manufacturer. It also, I don't think will pay you if you are importing drugs across the border. It would have to be drugs you buy in the United States, and so there's some, a footprint, of the drug lobby. But they did, support the eventual passage. The best way to reduce costs is to reduce demand, which is true. I mean, probably the best way is to get people a medical home, provide preventative care, make sure that they stay healthy, make sure that they have a family physician that they can go to who can manage their care, to change the fee-for-service system where you put providers at risk for the consumption of healthcare services. And so there are ways to address the cost, and that's the one thing that Massachusetts did not do. They covered most of the population, but they still have the cost issue. And so they had a commission get together and say, how do we address the cost issue? And that slide I showed, they ended up on this end, capitation. Let's find an organization, insurance company, let's give them the money. And then they're at risk for providing all the care needed by that individual, by that population. And so, they've seen they have to move way down that ladder. I think I've covered all the ones, maybe not this one. Is it true that while we can keep our current plan, we cannot change plans? No, that's not true. I mean, I think if you're on Medicare Advantage, I mean, you can always go into a Medicare Advantage plan. You can change your supplemental plan on Medicare. And then if you're on a Medicare Advantage plan, they have an open enrollment period every year. And so that's why you see Group Health, Blue Cross, and everyone advertising in October, November, December, because they're trying to get, if you're on Medicare Advantage, they're trying to get you to change plans. And so, and there's a lot of, there's a really, for the individuals who join an accountable care organization, they can switch, the next month to a different plan. And so there's really no lack of freedom to switch plans, which is sort of a hard thing for insurance companies because they're trying to keep you well, but if they raise a premium, then you can go to the next plan. But the whole idea between the exchange is that you can go online, and I think the exchange right now, the exchange is only open to people who are getting a federal subsidy, individuals who are buying on their own. And I think since the Republicans like the idea of the exchange, they'll try to open the exchange up to everyone, to a lot more people, to employers. And I think Blue Cross of Idaho believe that the exchange is where the action is going to be. And so they're going to be selling products more on a retail basis to individuals, to employers through these exchanges. And so they have to have products that are competitive. And the products on there are called the metallics. Interesting. On the exchange, there's certain structure of products. And the metallics are, the silver, the gold, the platinum. There's one other metal in there. And so they have to be sort of comparable. And so you can compare different plans, different costs. And that's, I think, how a lot of people will buy their insurance in the future. That is in introducing some market competition, but it's in the purchase of health insurance plans. I think that's it. Thank you.